London. And it is my great honor and pleasure to welcome you all to the IAC webinar. And this afternoon in particular, I am absolutely delighted to welcome my friend and colleague, Dr. Sinchita Roy-Chowdhuri. Next slide, please. Okay, well, Sinchita doesn't really need an introduction, but just to summarize some of her many achievements, you can see that she is currently an associate professor at the MD Anderson Cancer Center in Houston, where she is the Director of Molecular Diagnostics and also Molecular Cytopathology. Of course, we know of her work through many publications and presentations at international fora such as these. And amongst her vast research portfolio, I think the ones that we're most familiar with are her work on lung cancer biomarkers and also molecular diagnostics on small specimens, including cell blocks and biopsies. So without any further ado, and seeing that more and more of you are joining in, I would now like to hand over to Sinchita. Thank you very much and enjoy the afternoon.
Okay, well, hello everyone, and thank you, Ash, for that very kind introduction and for inviting me to be part of this presentation today. It is my pleasure to be here, and as mentioned by Dr. Chandra, I do cytopathology as well as molecular pathology, and so my talk today is going to be a combination of molecular and cytopathology and the future of minimally invasive diagnostics. I have no conflicts of interest to declare, sadly. All right, so I just wanted to throw this out there for some of you who may recognize this book. This was published in 1997 by Dr. Juan Rosai, right? And it was called Guiding the Surgeon's Hand, a history of American surgical pathology. And so when Dr. Rosai published this book, he was trying to describe what our role in pathology is. And it was primarily at that point, kind of guiding these large resections, like what needs to be taken out and how the surgeon should kind of perform in sort of the background of what the pathologic diagnosis is, the do's and don'ts. But things have started evolving since then, right? We're able to get, with all of the technological advances, we're able to get adequate specimens using these minimally invasive techniques, right? Like small biopsies, cytology specimens. And we can not only make diagnoses from them, but we're able to do some of the biomarker studies that are needed to guide the patient's management. So I look at the current role of us in pathology. It's not just guiding the surgeon's hand, which we still do, but also guiding our interventional radiologists, our bronchoscopists. And so all of our proceduralists who get us these small specimens, and cytology comprises a very large portion of it. So I'm going to start off with kind of talking a little bit about the small specimens. So like I mentioned, you know, anything that's collected through a minimally invasive technique is kind of lumped into the small specimen category. And this would comprise, you know, any of the small biopsies, core needle biopsies, forceps biopsies, as well as your cytology specimens, which would be your fine needle aspirations. And FNAs and core biopsies vary in terms of not just the procedure, but also the processing of the specimen. So conventionally, fine needle procedures are done using smaller needle size, so 22 gauge needles or smaller. Core biopsies tend to use larger needles, so 20 gauge needles or larger needles. And then as far as the procedure, as we all know, when we do an aspiration, the specimen is collected through some action, like cutting action of the needle, as well as capillary action of the specimen going into the needle bore. And then we put it onto glass slides, or we put it into a collection media. We make smears or liquid-based cytology. We can spin it down, fix it in formalin, make a cell block. So a lot of different options as far as our fine needle aspirations go. Core biopsies tend to be unidirectional. You collect a core of tissue. It usually goes into a fixative right away, hopefully 10% neutral buffered formalin. And then that gets processed into a paraffin block. We cut sections, and then you have your core biopsies that are stained with H&E. So what is the main goal of the small specimen? So there's multiple things that we're trying to achieve. So number one, of course, is establishing a diagnosis. So with any pathology specimen, the first purpose is we perform it because we're trying to make a diagnosis. Now, if you can also stage the patient based off that specimen that you receive, that's an added bonus, right? So for our EBUS procedures, when we go for a mediastinal lymph node, we're not only trying to make a diagnosis, but we're also trying to stage the patient. So you kind of get a twofer for that. The other thing that we want to do with these specimens is try to subtype it, right? We want to classify the tumor the best possible way, so that can guide the management of that patient. So in the realm of lung cancer, in the past, you could call it non-small cell or small cell lung cancer, but now there's an increased need to kind of subtype it, like whether it's an adenocarcinoma or a squamous cell carcinoma. And for that, we may need to do ancillary studies, because sometimes we don't always have the morphologic differentiation. And so you want to be able to use your small specimens to do these ancillary studies, whether it's for diagnostic purposes or for some of these prognostic markers that are used for therapeutic purposes. So as I mentioned, our tissue that we collect in this current day and age, it's not just for diagnosis, but also for these clinically relevant biomarker studies, right? So an example of where we use molecular testing in pathology. So number one, we have been using it for diagnosis and classification. And I think neuropathology kind of has been leading the field, where they're the first subspecialty in pathology where they've incorporated the molecular testing into their diagnostic line. So you cannot just call something a glioblastoma anymore. So you need to always try to subtype it, and your diagnostic line needs to include that molecular information that will decide how that patient's going to be treated. As far as predictive and prognostic information, we've been doing this for several years now. And oftentimes these terms are used interchangeably, but in reality, when you say predictive marker, you're trying to describe a biomarker that indicates therapeutic efficacy. So for example, EGFR, PD-L1, where the results of that biomarker study will decide how that patient is going to be treated. Prognostic markers, on the other hand, are independent of the treatment the patient receives. So it's the innate aggressiveness of the tumor. So something like TP53, which is a kind of a worse prognostic marker. So you use that in a way that's independent of whatever treatment that patient receives. So again, as I mentioned earlier, molecular testing is now standard of care in many solid tumors. Lung cancer is just one example. The main purpose for these profiling studies is that we're trying to identify molecules in specific signaling pathways. And we want to design drugs that target these specific molecules, and then decide which patients, depending on which patients show a positive biomarker, that they can respond to that specific treatment. So that's the premise of personalized medicine, where you use a treatment that's specific depending on the molecular finding that you detect in that patient's tumor. Now, I use this term integrative diagnostician. This is something one of our neuropathologists at MD Anderson uses. So Dr. Greg Fuller loves this term, and I love it too, because I think in pathology, we need to be that the integrative diagnostician, where we take the clinical information, we take all of the imaging findings, and most of this is available to us through the electronic health record, right? So we don't have to really, walk over to the patient's room, look up their charts anymore. So it's at everyone's fingertips. So you take all of that information, you put it together with the pathology that only we are privy to. So we look at it under our microscope, we know what it looks like. And then we have access to the molecular information. So even if you are not a molecular pathologist and you're not actually reviewing the sequencing, you have access to the results. So being able to put together all of these different components and integrate it into a diagnosis and a management plan of how that patient's going to be treated, that I think lies at the core of what we do in the current day and age in pathology. All right, so kind of like stepping back to where I started, we talked about FNAs and core needle biopsies as being the most common minimally invasive specimens that we get. And oftentimes they've been pitted against each other. A lot of people have argued about which one's better. And depending on, who you're talking to, if you talk to anyone in cytopathology, they're going to say the FNAs are superior. If you talk to someone in surgical pathology, they're going to say, no, core needle biopsies are better. And if you want to, read some of these really interesting review articles, there's one by Dr. Britt Marie Young and colleagues and Dr. Paul Vanderland that you can refer to that talk about, and the very interesting points of view of, how we consider which one's superior. When I look at it from at least the biomarker testing standpoint, molecular testing, I think, they're kind of complementary, and oftentimes it depends on a personal preference. So, whether you tend to choose a can of Coke versus a can of Pepsi. Oftentimes it depends on who is the consumer, right? So traditionally, when you look at core needle biopsies, they have been perceived to offer greater diagnostic detail, right? There's architecture, you're able to distinguish invasive disease from in situ carcinoma. It's easier to do grading on them. And of course, because you have a paraffin embedded block, you can get multiple sections. So they're easier to validate in terms of immunohistochemical studies, in terms of FISH or molecular testing. So in general, the perception in the community has been that we want to prefer core needle biopsies because they're easier to do some of these downstream assays. But in reality, when you look at cytology, there's so many different specimen preparations available, and each one can be utilized to do any of these studies, whether it's a DNA, RNA-based assay, whether it's FISH, gene expression studies, IHC. The specimens in cytology are processed a little different. Each one has its unique advantage or limitation. And you just have to kind of work around it and utilize it to the best advantage to make use of it. So if you look at it from the molecular standpoint, I think the biggest advantage we have in FNA is the ability to do rapid on-site assessment of rows, right? So because we can look at the specimen while the patient's still there, still doing the procedure, we're able to triage it better. We can collect adequate material. We can tell whoever's doing the procedure how to send that specimen, what is needed as far as diagnosis, as far as molecular testing. And then the aspiration technique tends to aspirate more of tumor cells, less of the stromal tissue. So in general, an FNA specimen tends to have a higher tumor fraction than, say, a corresponding core biopsies. The other advantage in terms of metastatic tumors to bone, these specimens in FNAs are not decalcified, right? We don't decalcify aspiration. So you don't have any of the artifacts that you get with decalcifying agents, like any harsh acids that are used for decalcifying core biopsies are detrimental to any molecular test. And if we are able to use non-formalin fixed FNA specimens, so your direct smears, your cytospins, liquid-based cytologies, they're not formalin fixed, and they tend to give, so anything that's alcohol fixed tends to give better quality nucleic acid. So that's another added advantage. Core biopsies, as I mentioned, tend to use larger needles. So obviously you're going to get a little bit more tissue than you see in an FNA specimen. So your overall nucleic acid yield might be higher. You have a paraffin block most of the, for all these biopsy specimens. So you can get multiple sections to validate some of these downstream assays. And that has been perceived as one of the biggest advantages for core biopsies for molecular testing. But as I mentioned, FNAs tend to aspirate more of the tumor cells. And this was a study that we did at our institution comparing our FNAs with our core needle biopsies. And we compared the tumor percentage in the FNA specimens. And as you can see from this figure here, FNAs tend to have a higher tumor percentage when compared to the paired core needle biopsies. And this was also reflected in the downstream assays, as you can see here. When we looked at the variant allelic frequencies, the FNAs tend to have a higher allelic frequency because they have a higher tumor percentage. So it makes sense that when you do the downstream assays, the allelic frequencies would also be higher. There was a study that was published from a group in Boston, and they looked at the quality matrix for some of these downstream assays, and they showed that your smears and liquid-based cytology tends to have better quality matrix than core needle biopsies and cell blocks that were fixed in formalin. So overall, the message that I'm trying to convey is that if you have the ability to do some of your molecular testings on non-formalin fixed FNA specimens, you may have a sample that has better tumor fraction that will give you better quality nucleic acid, and some of these downstream assays will perform better. However, sadly, cytology samples tend to be underutilized in the community, especially here in the United States, where it's a very biopsy-centric practice in most places. Molecular labs are kind of reluctant to accept cytology specimens if they're not formalin fixed. So if we send them formalin fixed cell block specimens, they will accept it because they've already validated their assays on any FFPE tissue for histology. And so they will accept the cytology FFPE cell blocks. However, because they have to do additional validations for non-formalin fixed cytology specimens, there's a general reluctance to take it. And I think part of it also stems back to our cytology practices, because cytology labs tend to process their specimens in a wide variety of different ways. If you take a survey of how things are processed in different cytology labs, you'll see we have different collection media, we have different stains, we have different fixatives. And there's no standardization across cytology practices in terms of how we process it. Now, for any molecular lab who's trying to validate an assay, they need to account for all of those pre-analytic variables that you introduce every time you process specimens differently. And I think that is probably the key reason why some of these reference labs tend to be a little reluctant in terms of accepting non-formalin fixed tissue, because they have not validated for all of the variable factors that are introduced during specimen processing. I think in addition to that, cytopathologists also tend to be a little reluctant to give up material that will be used for testing. So if you are going to test off a smear, you're going to be scraping cells off that slide, and you have to sacrifice that slide. So sometimes there are medical legal issues associated with the use of cytology material. And so there may be a general reluctance for that too. But overall, I think there is also the lack of awareness in the community. I mean, we still run into some of our clinical colleagues who will come in and say that I really need this test done on this patient. I didn't know you could do that off an FNA. And we're constantly educating our clinicians in terms of what you can do with cytology. You don't always need a core needle biopsy. And we encourage them to make more use of our FNA specimens for biomarker testing. Okay, so what I have been kind of trying to emphasize is that from a molecular standpoint, FNAs and core biopsies, we're not competing with each other. They're complementary to a large part. And this is an example of what I mean by that. So this is an example of a case where we got a biomarker request that included a bunch of different genes for mutational assay. We also had requests for IHC biomarkers. And if you look at the core biopsy on the left, you can see there, there's adenocarcinoma. They're like small clusters, but it's embedded in this stromal tissue that has a lot of fibrosis and inflammatory cells. Now, this core biopsy specimen, it's definitely adequate for doing these IHC biomarkers, right? We can do the things that they requested, PD-L1, HER2, MSI testing, because we are able to identify the tumor cells in there. However, if I'm going to do mutational analysis of this specimen, there's a chance that all of the wild-type DNA from these normal cells will drown out the tumor DNA that I get from the tumor cells, right? So you run the risk of a false negative result. And in this situation, if I look at the concurrent FNA specimen, again, highlighting what I mentioned earlier, look at the amount of tumor cells you have. There's so little stromal tissue. Most of the fragments that you have in here are your tumor fragments. And so your tumor proportion is much higher. The chance of a false negative is much lower. And you can scrape off these cells from the smears, again, provided your assay is validated in the molecular lab that you're using, and then do your mutational testing of the cytology specimen. Now, I've had people say that the molecular lab I'm using will only accept FFPE tissue. And I've told them that another option that you have, if you don't have a cell block from the FNA specimen, you could potentially scrape off the cells from a cellular smear, put it into a formalin fixative, spin it down, make a cell block out of those cells, and then use that for testing. Because when they're testing for molecular, they're going to be scraping those cells off anyway and extracting the nucleic acid material from those cells. So you're not so concerned about them preserving the morphology of the cells. So even if you scrape these off and they get a little distorted in your cell block, you should still be able to do molecular testing because it's an FFPE block and your molecular lab is validated to test from FFPE. Now, the other thing I also wanted to bring up, because recently we have been seeing an increasing use of a procedure that says fine needle biopsy. Now, so what is a fine needle biopsy? So it's something that kind of lies between a fine needle aspirate and a core needle biopsy. So we have specialized needles that can do a procedure like an FNA, but it is able to also collect adequate tissue, which might be needed for downstream testing. So that has been, there's been several studies in the literature talking about fine needle biopsies as an alternate way of collecting specimens for diagnosis as well as biomarker testing. And there's a bunch of different kinds of needles out there. I mean, true cut needles were the ones that used to be there for several years now, but they're kind of limited by the stiff design. And again, I'm not endorsing any of these needles. I don't work with any of the companies that manufacture these needles, but I just wanted to put it out there that they have these kind of specialized tips, whether it's kind of like a sharp core or a fork tip, or they have a beveled edge. So when you're doing your procedure, not only are you getting the aspirated material, but that tip will collect little fragments of tissue that can be processed into formalin, and you can make a good cell block. And when we look at those cell blocks, they actually look like little small biopsies. They're a little bit more fragmented than the long core biopsies that we're used to seeing, but they do have adequate amount of tissue, and it helps with diagnosis as well as some of the downstream testing. And this study here actually shows that one of the reasons why these FNB needles have gained popularity, because one, you're able to collect more tissue, and you can do fewer number of passes, and that helps from a procedural standpoint, but you're also able to collect adequate tissue for ancillary testing, and the fact that you don't need someone from cytopathology to be there during the procedure to do rapid on-site assessment. That also has been very attractive to some of our endoscopists who have been using these procedures for their EUS procedures for GI procedures. So now that we're starting to see more of these small specimens coming during the cytology procedure, the question that arises is that how do we handle these specimens? Who signs out these specimens? Are they processed as part of your cytology specimen and it's signed out by the cytopathologist, or do you separate it out? It gets processed as a surgical pathology specimen, and then you have two pathologists, your cytopathologist and your surgical pathologist, whatever subspecialty that is, interpret them separately, and you have two independent reports, right? So you have two choices of how you want to proceed with this. There was a survey that the American Society of Cytopathology did, and you can see some of the survey results that are shown here in terms of how people felt about either the cytopathologist reviewing all of the material or the surgical pathologist reviewing all of the material. Because if you're going to have one unified report, it has to go to one of these two pathologists, right? And I think the summary from this is that the argument is that cytopathologists are used to looking at small material. They're the ones who will be willing to look at the smears. Surgical pathologists may not be willing to look at the smears. They'll only look at the block, like the FFPE block, the fine needle biopsy, or the core biopsy, or whatever that they are getting. And they will ignore the smears. If all of the diagnostic material is on the smears, it might get missed. The flip side of that argument is that surgical pathologists, especially if you're in a subspecialty practice, are more attuned to the developments in the field. They're more in tune with some of these subspecialty classifications that are coming out. They have more expertise in that particular field. And that the cytopathologist may not be comfortable looking at all of that surgical pathology material. So, there's clear arguments for both. But in the end, as far as the reporting goes, separating out the FNA from the surgical specimen increases the likelihood that you could run into a discrepant result. Like you could have two reports that have two separate diagnoses depending on the sampling adequacy. You could have redundant testing where each pathologist orders testing on their own specimen. You could have reports that get delayed because one person's waiting for the other person to finalize their report. And of course there are issues with billing. So Dr. Martha Pittman, who was the president of the American Society of Cytopathologists, had created the cytopathology task force last year. And you can see some of the members that were on this task force. And the task that they had was looking at this unified reporting of small specimens, where if you are getting a cytology FNA specimen with these small biopsies, let's look into how we can unify this report. It comes to cytopathology and they issue this report that is unified. So now when we're talking about small specimens, and again, related to biomarker testing, I think I've been making a case for why we need to collect adequate specimen for not just diagnosis, but for biomarker testing. But the question arises is that what percentage of these cases remain inadequate for testing, right? Why are we talking about it? Why is the adequacy part so important in these small specimens? Because now we're not talking about these large resected specimens or excisions from surgical procedures, but little small biopsies, your FNAs. And when you talk about adequacy of these specimens, the adequacy depends on multiple factors, right? So it would depend on the number of tests you're going to do. So if I'm going to have a specimen and I'm going to do one single IHC assay, it might be adequate. But then if I break that down and I do a bunch of different things, IHC, FISH, molecular testing, I test 10, 15 different genes, you may run into this issue where it's not adequate. And a good example to use is non-small cell lung cancer, because currently in lung cancer, you have 10 biomarkers that you're required to test. So if you look at the guidelines for biomarker testing, there's 10 biomarkers that you have to test. And if you take an example, something like ALK, there's a whole multitude of ways you can test for ALK. You can do IHC, you can do FISH, you can test ALK by a molecular method. And so if someone is testing each of these 10 biomarkers by single gene assays, you may actually end up running out of tissue if you're using a small specimen. And this study that was published in 2019, of course, this is before we had the 10 guideline biomarkers. But even at that time, they looked at 8 guideline biomarkers, and you can see the more biomarkers that were added, the less number of specimens were adequate for testing. And most of these studies that they looked at were using single gene testing. The second thing from an adequacy standpoint, it would depend on the kind of tissue that is collected, right? So if the tissue collected is not viable, or if there is very little tumor, you get a big core of tissue or a lot of specimen, but most of it is just normal cells, that's not going to be adequate for testing. So for example, if I have a cell block like the one here on the left, no question, this is adequate. We have, adequate number of cells. Most of the cells are tumor cells. So the adequacy is not an issue. But if you have a cell block like the one in the middle of this slide, that becomes a problem, right? Because you have this tiny little fragment, you barely have any tumor cells in that. So this is probably not going to be adequate for testing. And then the third scenario where you actually have a lot of tissue, but you have very little tumor. So you see in the little red circle, that's where your tumor cells are. The rest of the tissue is just a lot of lymphocytes and fibrosis. And when I try to test this biopsy, I may run into this issue where it's just not adequate from a tumor percentage standpoint. And then the last thing, of course, is how that tissue is triaged and processed, because the processing can actually make quantitative and qualitative differences in the nucleic acid yield, the protein antigenicity, and how that tissue is going to behave in downstream testing. So that triage and processing component is what brings me to good tissue stewardship, because this is actually everyone's responsibility, starting from the clinician who orders the test, the person who does the procedure, to anybody in the lab who's processing the tissue and interpreting, reviewing it, and the molecular lab that is going to be testing. All of us are at that table, and we play a huge role in terms of ensuring that that tissue is adequate for testing. So, as I said, it's a multi-step process, and we have to be cognizant of every single step and how that impacts some of these tests that we do for downstream analysis. So how do you ensure that you get an adequate sample, right? So the first step is maybe use an image-guided procedure, because when you're doing the procedure, or your radiologist or your bronchoscopist or whoever is doing the procedure, if they can see that the needle is actually in the lesion, the chances of that person collecting lesional tissue is much higher than if you're kind of going in blind. And of course, optimizing the technique for the best diagnostic yield, whether that's looking at what needle gauge you want to use, the number of passes, the number of core biopsies, whether you're going to do concurrent procedures, all of that kind of plays a role in ensuring you get a good sample. And of course, the skill and the expertise of whoever's doing the procedure plays a huge role. So I showed you this book before. Of course, right now, we're not talking about these big surgical procedures, but we're talking about minimally invasive techniques. And for that, rapid on-site evaluation actually plays a huge role in terms of guiding adequacy. So when we do ROSE, whoever does the procedure puts a tiny portion of the aspirate onto a slide, we stain it during the procedure, look at it, and then depending on what I see, I can triage that tissue. So if I see something that makes me think this might be lymphoma, I can send it to flow. If I think this is an infectious process, I can send it to micro. But if I see a lot of tumor and I know that there's going to be a need for molecular studies, I can triage it so that, they can collect more into the rinse to make a good cell block, or I can make additional smears, because if I'm going to be testing off smears, I want to make sure I'm collecting adequate tissue. So what is the role of ROSE? Has ROSE been shown to increase diagnostic yield? And the answer is no, but ROSE can help guide the procedure. And with that, it can reduce the number of passes. You can kind of triage it in terms of how you want to collect the tissue. You can also provide feedback to whoever's doing the procedure so that they can, with time, they actually get better with technique. And if you are collecting an adequate specimen up front, you end up reducing the cost, because that patient does not need to come back for a rebiopsy. However, there is a lot of hesitation in the community for widespread adoption of ROSE. And you can look at this survey that came out from the ASC that actually looks into some of these reasons why people hesitate and why there is kind of a lack of enthusiasm in terms of widespread use of ROSE. Most of it kind of boils down to resources, not having enough people. It takes too much time and the logistics of performing the procedure. But I think everybody agrees that if you have the ability to do, and you have the right infrastructure, ROSE does improve the adequacy of the tissue collected. And this study, which actually looked at tissue that was collected for clinical trials, where the main purpose of collecting a tissue is to ensure that you're collecting adequate sample for biomarker testing for a clinical trial, showed that with the use of ROSE, most of the specimens were deemed adequate, and it minimized the number of inadequate biopsies. So what if you're in a practice where whoever's doing the procedure does not want to do an FNA specimen and they're only collecting for core biopsies? One option is to do a touch preparation. And again, you don't want to do a touch preparation like the one on the right, where all of the material ends up on the touch prep and there's nothing left in the core biopsy to make a diagnosis. So if you're doing a touch preparation, teach whoever's doing it to be gentle, no vigorous kind of rubbing of the core biopsy on the slide. You just lightly touch and then pick, touch and pick, like the picture that you have here on the left. So step 2 is the specimen processing part. And I talked about, the differences depending on how you process these specimens. And oftentimes people think that if you have an FFPE block, that would be perfect, but FFPE blocks are not the same, right? And the pre-analytic variables will depend on what you did before that block was created. If your block is fixed in, is collected in something else before it's fixed in formalin, you're introducing pre-analytic variables, and those may actually play a role in the downstream testing. And this was a review article that came out looking at FFPE specimens and how the molecular integrity of samples will depend on how that specimen is processed, what fixative you're using, how long it's been sitting before it goes into fixative, how long it's been sitting in formalin. All of those things actually play a huge role. The third thing is, which is of importance, is how you handle that specimen after it's collected. And so if you anticipate the need for ancillary studies, preparing upfront is probably a better way. So, if you have a block, whether you want to cut upfront sections or you want to do a shallow sectioning at first, make sure you have diagnostic material and then cut your sections. If you're going to be testing off smears, if you're going to need additional smears, all of those come into play when you are setting up your workflow SOPs and trying to optimize that procedure for downstream analysis. Because the last thing you want to do, you want to have that clear communication between all of those stakeholders, because you don't want a situation where you have a block like this that was collected, that had plenty of material, but then you recut that block for biomarker studies, and all you have is a tiny little piece of tissue. So that communication between whoever's ordering the test and doing the procedure and whoever's doing the downstream processing needs to be there. And then the last thing in this whole workflow is, and I think this is probably one of the biggest roles we have in pathology, is modulating the specimen for whatever biomarker assay that you're doing. So as I mentioned earlier, you want to have a certain amount of tumor in your sample because you don't want to drown out the tumor DNA and be the ability to detect your mutation by all of the non-tumor cells that will dilute your DNA. And this is an illustration of why that's important, because it kind of relates to the limit of detection of your assay, which is the analytic sensitivity. So if you have a sample like the one on your left, where there's 40% of your cells are tumor cells, every tumor cell has one wild type allele, one mutant allele. So only 20% of the alleles in that specimen are mutant alleles. So you need a sensitivity of 20% if you want to pick out that mutation. So the lower the tumor fraction in your sample, the more sensitive your assay needs to be. And so, for example, in this specimen, this was a lung adenocarcinoma specimen, and you have tumor cells, but you have a lot of non-tumor cells in the background. Now, when this specimen was tested using Sanger sequencing, you could not pick out the mutation because of the noise in the background, because that Sanger sequencing is not a very sensitive assay. But when you use that same specimen and you test it with next generation sequencing, which is has much better sensitivity, you're able to pick out the mutation that was present in this specimen. So the final piece that I want to talk about is integrating molecular and cytology. So that's where this whole concept of molecular cytopathology comes in. And when it comes to molecular cytopathology, there's a rule of three. So you have to know three things. You have to know your test, you have to know your specimen, and you have to know the clinical relevance of what you're testing. So when I say you know your test, you need to know what kind of assay is going to be used, what the capability of that assay is, the sensitivity, what the limitations are. Because if the assay that you're using is not designed to pick out certain things that you are looking for, it is not going to be able to pick it out because it wasn't designed to do that. So you kind of have to know the analytic sensitivity of your assay, but also the clinical sensitivity, which is what that assay is capable of picking out. You also have to know your specimen, and that's why I say pathologists are in the best possible seat at that table, because we're the ones that actually look at the specimen. We know how much tumor there is. So if it's a false negative, we're able to say that this result doesn't make sense because, there wasn't enough tumor, and I know that this specimen should have been positive for something. So we can modulate our specimens and we can prepare them best for whatever assay that you're going to be using for testing. And then finally, the clinical relevance again. And this is where our integrative diagnostic skills come in, right? Because we can make those correlations. We can say when there's a false negative or a false positive result, and we can explain the clinical significance of the findings that are picked up by molecular. So how do we harness the true power of these small specimens? And I'm going to show a few examples before I finish. And so let's start by looking at thyroid cytopathology. So in thyroid, FNA is the preferred sampling modality, but we still do have quite a high rate of indeterminate diagnosis, right? And in some cases, people have made an argument that if in an indeterminate diagnosis, if you're going to be repeating the procedure, should you use a core needle biopsy versus a repeat FNA, right? And there are arguments. If you're going to be doing a core biopsy in such a vascular organ, there's an increased risk of adverse events. Core biopsies have a higher cost if you have to do that. And inconclusive rates are also still kind of high, maybe not as high as an FNA, but they're still high. And so if you're using the Bethesda classification for thyroid, you'll see that the indeterminate diagnosis actually have a recommendation for considering molecular testing to help refine that diagnosis. And there are a bunch of commercial assays, at least here in the United States, we have the option of picking any of these commercial assays for thyroid cytology. And each one comes with, they're a little different. Some are gene expression assays, some look at next generation sequencing. And most of these you have to collect in a proprietary solution and send it to the company for testing. Some of them will test off smears, but these are all send out tests. And there have been several publications that have looked at doing the same kind of test in-house by using residual sample that you have from these thyroid FNAs. And they've shown that residual liquid-based cytology, you can do next generation sequencing if needed. Now, I said the power of molecular cytopathology, right? And so what is so cool about these particular molecular techniques is that we're doing these procedures not on malignant tumors, right? These are indeterminate diagnoses. So most of the time when we think about molecular testing, at least from a surgical pathology standpoint, we're talking about doing molecular testing on tumor specimens. We circle the tumor, we do a tumor percentage estimation. But here we're talking about doing molecular testing in something that is an indeterminate diagnosis, and then using that to kind of have a more definitive diagnosis to provide management guidelines. So that is really cool. And we have been doing that in cytology for decades. We've been using molecular testing in atypical diagnosis for GYN cytology, with HPV assays from cervical cytology. We've been doing more recently HPV assays on head and neck cancers. And then in urine cytology, again, if you look at the parent system, the atypical urothelial cell diagnosis actually has a recommendation of using molecular testing in conjunction with the cytology to help from a management standpoint. How about cases where there is no diagnosis of malignancy? So pancreatic cyst fluids is a good example of that, where oftentimes the cytology diagnosis for an IPMN or any mucinous neoplasm, we don't see any tumor, it's signed out as negative, but we are able to use the residual cyst fluid to look for different mutations and then classify these cysts into, whether they have a higher chance of neoplasia, and also classify them into whether we think it's a non-neoplastic cyst or a cyst, serous cyst adenoma, or a mucinous neoplasm or an IPMN. So that's the power of molecular cytology. And we said, we have these residual liquid-based cytologies that have been used for some of these testing. There are a couple of different institutions that have shown that you can take not just the residual fluid, but also spinning down, take the supernatant, and then adding it to the residual fluid, and then using that for molecular testing. And oftentimes, as you know, like these supernatants are thrown away. They're not used for anything. But being able to utilize that for some of the downstream assays is absolutely fascinating. At our institution, we actually did several studies where we looked at just the supernatant. So we're not even adding it to any residual fluid. So this is like when we spin down and make our cytospin or our cell block, the supernatant that we typically throw away, we were able to extract adequate amounts of DNA to do next generation sequencing studies and do molecular profiling on patients that have tumor. So if you have a patient that has limited material on your block or on your smear, you could potentially use the supernatant to do some of these studies. And since then, there've been like multiple publications that have looked at supernatants from FNAs and other body fluids that can be optimized for some of these molecular tests. And the interesting thing is that it's not only that you're kind of doing more with less, but this less is actually faster because, now you're cutting out all of the time for processing the slides and then scraping off those slides and trying to extract DNA from that. But you can just take that fluid, extract DNA, RNA the same day of the procedure and run some of these downstream assays. So you save on time, but you also have cost savings because you're, again, kind of cutting out some of those intermediary steps. So again, if you're interested in it, I would point you to this publication where they actually looked at some of these matrix. And it's not just supernatants from FNAs, but they've done it in biliary brushings. People have done it from CSFs, fluids, effusion specimens, urine specimens. And so there is this whole new world of liquid biopsies using cytology specimens. And again, this beautiful publication from Cornell talks about some of these applications and the challenges that you have with these new substrates for liquid biopsies. So I wanted to summarize this by hopefully I was able to highlight that minimally invasive diagnostics, the future is super bright. There's a whole range of different things that we can do with it. These small specimens are not just suitable, but often they're great for molecular testing. They work hand in hand. So it's not FNA versus biopsy, but let's put them together and make the most of it. And as people in pathology, we play a key role in triaging and handling these specimens so that we improve the success of these downstream assays that we're doing on small specimens. And so with that, I just wanted to leave you with this quote that I think is really, it kind of embodies what I was trying to highlight in this talk, is that 20 years from now, you will be more disappointed by the things you didn't do than by the ones that you did do. So go out there, explore, do new things with cytology, and move the field forward. And again, thank you for being here today. It was a pleasure. And I wanted to thank the organizers and IEC for inviting me. And I am here now. I think we have about a little less than 10 minutes, and I'm happy to answer any questions. Thank you. And I've left my email and contact information. So if I don't get around to answering your question, feel free to reach out to me if needed. Thank you.
Sinchita, thank you so very much. You know, one of the drawbacks of virtual meetings is that you can't hear the sort of rapturous applause that you're used to in when, you know, talking to big audiences live. But, you know, if you want to hear Sinchita live, the nearest opportunities will be arising in Budapest and also certainly in Austin, Texas, at the annual meeting of the ASC, and then also in December in Naples at the annual molecular cytopathology conferences.
So I'm going to be in Austin and in Naples, but I'm not going to be in Budapest, unfortunately.
Okay, well, it's a shame we'll miss out, but you know, all the more reason for us to come to Austin and to Naples to hear you live and in person.
Come over to Texas. It's not always as hot as it is right now, so it's going to be in November, so the weather is going to be better.
Okay, great. So, Sinchita, we've got a few questions, and I'm sure there'll be more coming. And of course, there's, you know, thank yous and congratulations, and you know, some tweets also already appearing in, you know, just a gratitude and appreciation of your time today. I will pick up on a big question first, which is about guidelines for specimen adequacy, you know, for genetic testing in particular, in core biopsies and FNA samples. Is there somewhere that you could sort of refer us to?
Yeah, and yeah, I mean, I apologize because I did not include that in my slides because I was kind of limited with the time frame. But at least because, you know, I think one of the areas where we've done a lot of biomarker testing, and it's one of the tumor types where there's so many biomarkers that are required for testing, is lung cancer, right? So in non-small cell lung cancer, as I mentioned, we're now required to test for 10 different things, and so at least in the lung cancer realm, there are guidelines that the College of American Pathologists issued, the recommendations. I'd say we published in 2020. So they're published in the archives. And if you have a hard time locating it, reach out to me and I'm happy to share that reference. But they actually had guidelines. So it was an evidence-based review looking at the literature to give specific recommendations in terms of collecting for all of these different procedures. So whether it's an EBUS procedure, the transthoracic aspirates or biopsies, bronchoscopic procedures, even fluids, fusions. There were recommendations of, you know, how you want to collect, what kind of needles, how many passes, how you want to process them. And so typically, if someone's looking specifically for guidelines, I refer them to the lung guideline, because that's one area where we have very specific recommendations. And I would imagine, because more tumor types are now being required for biomarker testing, that if we follow guidelines for one where there is evidence-based literature, it would probably work for all other specimens too.
Absolutely. Sinchita has been actually very modest in what she hasn't mentioned, and so I'm having to hold up to the camera is her excellent book, which which was first published in 2019, and I have to say, I learned a great deal from it, Sinchita. And in fact, when just reading what your last slide says here really applies to me. Having had to learn molecular cytopathology in my, middle age, and, feeling almost like, how am I going to get through the rest of my career unless I, teach myself some molecular cytopathology? And your book has been amazing in that respect. And in fact, it has helped in my own department to develop, molecular testing for FNA of, say, salivary glands, just using FISH on a direct pap stain smear, after just photographing or scanning the slide, and just, then you lose that slide, but at least you get confirmation of your, salivary gland tumors. We had been doing Eurovision FISH testing on urines, but we are also now going to try and expand it into, biliary tract brushings. And very recently, we also validated HPV testing in head and neck FNAs for squamous cell carcinoma metastases, and bypassing P16 or HPV testing through FISH. And now next we're looking at thyroid to be able to develop some sort of an alternative in-house panel. So it has been a journey. And initially, I think a lot of us feel that we don't have any formal training or qualification in molecular cytopathology, but don't let that stop you, would be my message to those of you who are thinking, wow, how do I ever deliver this? Take up one small project at a time. And it might take you 5 years to be able to do, what I've just described to you, but it all becomes really possible. So I think we still have a few minutes. Sinchita, if you're okay for time, I see another couple of questions coming in.
I just want to make one comment. I mean, thank you for sharing that. That's really great and very gratifying to see, more people adopting. But again, I can't take credit for this. Molecular cytopathology existed before me. And, like some of the pioneers in the field who even coined the term, I think Professor Salto-Tellez and Fernando Schmidt, I mean, they were pioneers in the field who introduced molecular cytopathology to the world. And I am just fortunate to be, in the right place at the right time, and have the ability to kind of work in this exciting field. But it's funny that you mentioned that, having to learn something. Of course, a lot of us learned molecular cytopathology as we came along in our path in pathology, but now we've got to all learn artificial intelligence, right? Digital pathology. So, that's the cool part of being in pathology. It can't, like, just when you think that you're learning something new, the question gets changed and you have to learn something new again. So we keep it exciting.
Absolutely. Sinchita, modest as always of your own achievements, but so a couple of questions which you may have already sort of answered in part. Experience with molecular testing from already stained smears. So which is what I was just talking about, FNA smears, sacrificing the pap stained slide for performing, either slide scrapings for next generation sequencing, if it's from an EBA specimen, or using them, whether they're for salivary gland or thyroid aspirates. Is there anything that you would like to add to using already stained direct FNA slides?
Yeah, so again, people ask that, if we're going to be using smears, do I have to keep it unstained? I mean, you can use anything. The main thing is that whatever test you're doing just needs to be validated on that specimen type. So whatever fixative, like whether it's alcohol fixed or it's an air dried smear, whether it's a Giemsa kind of stain or a pap stain or it's not stained, you just have to make sure that you run your initial validation to show that whatever you're doing is work. Because the important thing to realize is that all of these biomarker studies that we're talking about, they're actually used for patient management. So you want to be absolutely certain that whatever result is reported on your specimen is accurate and reliable. And because the last thing we want is for our clinicians to say that, oh, but half the time it fails on cytology. I didn't know you could do it on cytology and it's not as reliable. And so, because we're constantly telling them that, no, you can do what you do on your histology specimens, but you can do it better and you can do more. And so now if you include, like I've been trying to advocate for inclusion of FNAs in our clinical trials, because usually when they write these clinical trials, there's no cytopathologist involved, right? So every trial is written where they only do core biopsies, 5 core needle biopsies, 3 core needle biopsies, and there's no FNA. And I'm like, how do you even know? And we're looking at the touch preps to make sure they're adequate. But I said, if you incorporate cytology in your trial from the get-go, you're likely going to get better specimens that you can do more. And you're not just reliant on a core biopsy that shows up as like necrotic and doesn't have any viable tumor in it.
Absolutely. A couple more questions, Sinchita, before we let you go. And you've got a full day's work ahead of you. It's only 9 o'clock in Houston for you. So again, a question coming in about utilizing the supernatant specimen for molecular studies. And do you use that in advance or after making the cytological diagnosis?
Yeah, I mean, the supernatant is like literally like something I absolutely would love people embracing more and utilizing more, because I know the potential of what's in it. Again, most of our testing at our institution comes from our clinicians. So it's not pathologist driven. So we need a biomarker request from the clinical team. And that typically comes after the diagnosis is made. So the report gets signed out, they put in a request, and then we test it. So if we knew ahead of time, and we've talked about it, like having reflex testing. So I think in my ideal world, I would have an EBIS procedure where I would look at the smears. I tell our bronchoscopist that this looks like lung adenocarcinoma, and I would take my supernatant and be able to run my assay and get my test results, maybe even before my final diagnosis on the cytopathology, because there are these platforms now that can rapidly screen, and you can test for EGFR and BRAF and fusions, and I could do it off my supernatant within hours and report it out probably the same time my lung adenocarcinoma cytology report gets signed out. That is the world that I want to be in. We're not there yet, at least at my institution, but I'm sure there are people out there that can make it happen. And if you have the right infrastructure, that may be possible.
And the last question and a comment, which I'm going to read out to you. In case the tumor percentage is low, do you consider microdissection or cutting several slides? This is the reason why I would like to know the threshold for sample size and tumor percentage to decide whether I can try more with this specimen or tell physicians to retake the biopsy.
Yeah, I mean, that again, I mean, I would probably need a lot of time to kind of go into the details of that. But yes, for every case that we send for testing, we try to circle an area. We call it like tumor mapping, right? We try to circle an area so that we increase the tumor percentage. So oftentimes in EBIS cases, you have a lot of lymphocytes and you have these little pockets of tumor. So we will circle meticulously each area of tumor. And then our molecular lab techs, if it's a big area circle, they grossly manually macro dissect. But if there are small areas, they will micro dissect. So most of the time we do it under a dissecting microscope, and they will take a needle and take the tip of the needle and dissect out every little circled area. So that's what we call our manual microdissection. And again, the purpose is to try and increase the tumor fraction, but you also need to have a certain number of tumor cells to make the DNA or RNA yield that you need for your assay. So there has to be adequate number of cells. And there are places that actually use laser capture microdissection. Again, you need special equipment and it's a little tedious. So we don't use it in our clinical workflow because we're a very high volume lab. And but that also is an option to kind of capture cells and microdissect them.
Thank you very, very much indeed.
Thank you. Thank you for having me. And like I said, if there are questions that I didn't get to, feel free to send me an email or reach out to me on Twitter. Thank you.